Okay. My schedule's off, so I was saying that my kids are home and that just throws everything off. Endocrine system today, and then neuro next week. And then I think that's it for the lecture course, and you guys have then the final exam. There's still a few emails I know people want to meet up with just to go over some things. I'm juggling this in undergrad classes, undergrads going into finals. So if I have not replied to you, I'm dealing with their courses and an exam I have to post tonight. So once I get through all that, if I owe you an email or something, I'll be getting back to you. Would it be possible to access the rest of the assignments for the semester so we could complete everything ahead of time? Laura, if you want to email Marnie and Jennifer, because they take care of that, and ask and CC me on it, that's probably the fastest way to get that done, because I sort of just give that to them. Thank you. I have too much on my plate. But I have no problem with that. I think we do it to not stress you guys out, but if you guys could do it, it's always better to get it over with. I agree. Thank you, definitely. Um, what else is there? Same exact format type exam, 10 questions each of these sections. So it's going to be endocrine, 10 from neuro, 10 from renal, 10 from GIGU. I don't know if you guys saw on Brightspace, I had opened up another document. Anyone seen that? It has like some YouTube videos on there to help, and so hopefully that you find that helpful as while you're studying. It has some explanation and also a different breakdown of the GIGU system. So hopefully that will make things easier as well. Um, so there's no extra credit in this class, as is just stated in the syllabus. The breakdown of the percentage is predetermined just to make it fair to all students. So because no one can get over 100, right? So there is someone who has that limit, offering extra credit doesn't really, it's not, I guess, fair to them. So it is predetermined amongst faculty. But the hope is, and the reason we have the credit, the quizzes, the individual and group assignments, is to offer you almost same kind of way, like an opportunity to have points outside of the exams. So hopefully you saw that. Okay. Let me go ahead and get started here. It's not a long lecture, but endocrine can be, either you hate it or you love it. So it's one or the other. So I guess you'll let me know where you fall. And when it comes to endocrine, I didn't really put diabetes in here just because you'll be talking a lot about, especially in primary care, pediatrics and all that, it will come up time and time again. I didn't want to spend too much time on that. Also because I feel like most people are, pretty well versed on diabetes and the basics of the differences between type 1 and type 2. And again, you'll be going over that again in your as you continue on in your schooling, that will come up in the pathophysiology of that. You'll definitely get it in advanced pharmacology. And we've talked about like hyaline vascular like issues that relates to diabetes and glycolysis in regards to diabetes. So it has come up in advanced path in that way, but um, I could get into the isolates of Langerhans cells and all of that, but there's so much more to go over as well in this. But that is the entire is also key in on what we mostly see on the found. It's just a lot of it is it is a lot of information. On the trying to think, I know the topical outline, the outline I put out, the exam outline for exam 3, I did put some questions on there to sort of focus your studying. That is meant to help you sort of gauge where questions will be coming from on the exam. Because it is just 10 questions like per lecture. What you think about all the information you have, we try to spread it out amongst all contents. I'll go back to review the outline I sent out to see, make sure that it sort of helps you focus on where where questions will be coming from to help focus your studying. But if you look, I think there were questions I did place on there to help that as well. Okay. Let me move some of these. My boxes are all over the place. Thank you. Take the mac and cheese that way, please. Thank you, love. No. Take the macaroni and cheese to the kitchen. Okay. So I wanted to, I know you could laugh at me. You should laugh at my life right now. Let's see. I have to laugh or else I'll cry. So I wanted to, when I go over the endocrine system, I realized I had these PowerPoint up and then these slides, but I wanted to at least, let's go through this real quick because I think it's going to help the conversation in those previous slides. So just make sure we're all on the same page. You have your hypothalamus that talks to the anterior pituitary through the CRH, which is the cornotropic releasing hormone. That hormone, when it's recognized by the anterior pituitary, then releases ACTH, which is the adrenocorticotropic hormone, which then talks to the adrenal cortex to release cortisol, so your T cortisol, which is the hormone needed for like stress. You can have high stress levels, fight or flight, and so forth. And then there's what's called the negative feedback. When your body recognizes high enough levels of cortisol, it then sort of turns off the hypothalamus anterior pituitary to slow down the production of CRH and ACTH. So I wanted to sort of like address this first to make sure we're sort of on the same page and sort of, I don't know if you guys look at these PowerPoints before we meet. I think it's helpful so you can sort of know where the conversation is going today, but I want to make sure this is understood that it's a hypothalamus talking to the anterior pituitary, going to the adrenal cortex, and then that feedback loop when the cortisol levels are high enough that then turns off those other mechanisms. Okay, so want to make sure that was there. So I'm going to negative feedback loops. That's what a negative feedback loop is. So it's that controlling of an increase or decrease of one hormone causing an inverse relationship in another. And an example I just said was cortisol going high, which then causes ACTH to go down. And you'll see that in the thyroid, you'll see that as well, where if TSH is high, that's an indication that T3, T4 is low. That's how they talk to each other. So TSH is sort of nudging T3, T4 to wake up. It's same things as discussions, that negative feedback. The example wrote here, increase in the plasma ACTH decreases serum cortisol production and released by the adrenal cortex. I think the better example, which is more common that we'll see, is an increase in cortisol causes then a decrease in the CRH and the ACTH. So again, it's really just that negative, that opposite is really what you want to think about, the opposite communication, where one goes up, one goes down, or if one's down, the other boosts the other one up. And we'll see that time and time again within the endocrine system. Something else to be familiar with is called a stimulation test, and a few stimulation tests we'll talk about today. And one reason for this is to evaluate hypofunctioning disorders or to find out like where the problem is. So the example I wrote here is the ACTH stimulation test is used in the workup of like low cortisol levels to see if low cortisol is due to either, is it adrenal hypofunctioning or like meaning is the problem at the adrenal glands or is it at pituitary or the hypothalamus? Like at what level is the ACTH a problem or is cortisol a problem? So if ACTH does not cause an increase in the cortisol, the problems with the adrenal functioning is adrenal hypofunctioning. So what does that mean? I always have to step back as how to explain this. I do think it can be sort of confusing if you have to really like think through the endocrine system. If ACTH does not cause an increase in serum cortisol. So first, I always think about like what's supposed to happen, right? So increase in ACTH is supposed to cause an increase in cortisol, right? And when you have high enough cortisol, then it's supposed to turn off the ACTH. So if you increase that ACTH and it doesn't cause an increase in cortisol, right? That means ACTH is there, but the adrenal glands is not responding to that, right? Or if ACTH causes an increase in serum cortisol, then the problem is that you don't maybe have enough ACTH, right? So the problem is with the pituitary or it's with the hypothalamus. And I was sort of the example I give is like if you put, because I just had to come from the car dealership because I don't have air condition, and that's going to be a problem coming up. In this situation, in regards to the endocrine system, if you were to put gas, let's say, in your car, right, and the car still does not work, then you know it's not a gas problem, right? It might be like an engine problem. So you want to think about it in the same way. So if I give you ACTH and I know I'm giving you what you need, and the cortisol system still doesn't function, then I know it's a adrenal problem, right? Versus if I give you ACTH and cortisol responds, the car moves, then I know the issue really isn't with the cortisol, it's with then the functioning or the actual production of ACTH. So thinking about it in that way. If I give the car gas and the car moves, then I know that, oh, it never had gas in the first place, right? So I know that's where the problem lies. So sort of thinking about that in the same way, trying to solve troubleshooting where the problem is coming from. And there's something called the suppression test. So when you're in the suppression test, you're evaluating hyper-functioning endocrine disorders. So if you have some like a high hormone level that you want to suppress down, and you can find out what suppresses it, then you can figure out what is communicating with what. So the example here is in low-dose dexamethasone. So low-dose dexamethasone is like similarly to giving someone like cortisol levels. So if you give someone a low-dose amount of dexamethasone, as a suppression test, that can evaluate hyper cortisone levels. So you can find out, is the cortisone due to a pituitary issue, adrenal issue, or is it maybe an ectopic Cushing syndrome where like cortisol is being released from some other source, like maybe from cancer, something like that. If cortisol is not suppressed in Cushing syndrome with a low dose dex, then you know that that problem is coming. There's some lack of communication. Normally, it's due to, again, some sort of ectopic conversation, which we're going to talk about later on today. And most hyperfunctioning endocrine disorders cannot just be easily suppressed. It's not like you just give cortisol and it suppresses ACTH release. Normally, if you give cortisol in a normal functioning endocrine system, it's supposed to decrease ACTH. So again, think about what's supposed to happen and then what you're trying to accomplish and what it could mean if, if there is a communication there. So again, the example here is you give low dose dex, you're expecting it for cortisol levels to go up to then turn off ACTH, right? If you give cortisol levels to a certain level and it doesn't turn off ACTH, then you know there's another problem in communication with the ACTH. Can you give an example of an exam question for this? Oh, yeah. Thank you for bringing that to my Laura. So, hmm. Let's see. A nurse wants to evaluate a patient's, we're going to use the term Cushing syndrome, which means just high cortisol levels. So the nurse gives a low dose, is expecting to give a low dose dexamethasone to a patient to evaluate their Cushing syndrome. The patient the next morning shows suppressed levels of ACTH. And again, at this point in the lecture, I don't expect you to necessarily get this, but the next morning the patient shows low levels of ACTH. The nurse interprets this to mean, what does that mean? If I give you cortisol levels and it suppresses your ACTH, that means that your body then is responding normally, right? It's responding in a way I'm expecting it to decrease its ACTH, which then you can surmise that that ACTH then is usually in the pituitary. Like that release of ACTH is properly being released in the ACTH, in the pituitary. So this slide really is meant to give the definition of suppression tests. As we go through the lecture today, you'll find where this fits in, but that would be an example of that. And again, it's really just understanding that connection between what you'd expect cortisol levels to do and how that relates back to the pituitary system. So the pituitary is working well in that question. Exactly, Jacqueline, right. So it's working because it responded to the high cortisol levels. It recognizes, oh, it's elevated, I need to come down, right? The negative feedback loop. So I can repeat what the nurse expects that is to mean. It means, like Jacqueline was saying, that the pituitary system is working, the ACTH decreased, and it responded as a negative feedback loop to the cortisol levels. So the answer would be that so the question was that the ACTH was decreased the next morning and how the nurse interprets that. The nurse would interpret it that the pituitary is working. Is dexamethasone supposed to mimic cortisol? Yes, exactly. Cortisol is an analog to dexamethasone. So why does a patient have elevated cortisol? Our adrenal cortex? Exactly. There could be a tumor. And again, that's what I'm going to get into later on today. But that's an example of how you would do a suppression test to see if one would suppress the other. Okay, good questions. So again, looking back at this is usually my starting point, and I tell anyone who has sort of, you really in endocrine system sort of have to step back because it's sort of abstract, and think about what's supposed to happen, how's communication supposed to look, and then throw the question in there, the monkey wrench, and be like, okay, now what does this mean, right? And then looking at it from that perspective. Don't memorize, like this talks to this and this goes up, because it can be very confusing in that way. But if you understand the feedback mechanisms, and you throw a problem in, and how you should then understand how that problem reacts in the situation. Okay, so yes, and we'll talk about reasons for elevated cortisol. Another example here, which we see, is like hypothalamus, and then you have your TSH in the anterior pituitary, then you have your thyroid. It's the same examples of feedback and negative feedback loops. So when you have elevated, as an example of this, elevated T3, T4, the negative feedback would be what? A decrease in TSH, right? So that's your negative feedback. You have elevated of 1, T3, T4, at a low TSH. In the same way, your TSH, when it is elevated, that is meant to then communicate to the low T3, T4. And when the T3, T4 then goes up, then the TSH responds and then goes down. So that, again, is an example of that negative feedback loop. Okay, so I'm going to talk more about these. Something else I wanted to discuss, because I don't really talk about it so much in this course, but you'll hear time and time again when people are discussing endocrine disorders, are the terms tertiary, secondary, or primary deficiencies. So when you say primary deficiency, like a thyroid, like hypothyroidism is a primary deficiency, meaning it's coming primarily from the primary source, which is the thyroid. If it's a secondary deficiency, then normally that means it's one level up. So second, meaning, just 1 second up, which would be like the TSH anterior pituitary. So the problem, let's say it's hypothyroidism, but it's a secondary deficiency, would be not the thyroid as a problem, but secondary would be the second one up, which would be the anterior pituitary. Or let's say you see the word tertiary deficiency, then it's 3 layers up. Tertiary being 3, so 3 layers up, which would be, in this case, would be the hypothalamus. So if you say hypothyroidism due to a tertiary deficiency, that means the deficiency is coming from 3 layers up, which is the hypothalamus. So it's a term that you might hear I've heard time and time again. Oh, it's a primary deficiency, meaning it's primarily an issue with the thyroid. And normally I hear more so with hypothyroidism as a secondary, tertiary, or primary deficiency. And really that just tells you where the problem is occurring. Okay. So let's talk about first, we're going to work our way from top to bottom. So we're going to talk about pituitary disorders first. How would this apply to things like tumors or trauma? So good question. So depending on what the tumor is, for instance, so the tumor, let's say, is in the hypothalamus or the pituitary. So let's say it's an adrenal issue, but the adrenal glands is not the problem, right? Adrenal would be the primary. Let's say the problem was in the hypothalamus, that's my tertiary level, right? So it tells me that it's not an adrenal issue, even though I'm seeing it at the adrenal glands. The actual problem didn't stem from the adrenal glands, it stems from the hypothalamus. Good question. Okay, so pituitary disorder. So anterior pituitary glands, you could have firstly a pituitary adenoma. So if you guys remember the term adenoma from the cancer slide, it's a benign tumor of the anterior pituitary cells. It can be functioning cells or non-functional. So functioning means it's not just a tumor in mass, but it also produces hormones. Or it could be non-functioning, means it's just actual like benign cells that are there doing nothing. Normally what we see are non-functioning tumor cells, then the problem is more of just the cells itself, the mass, the pressure that it brings, and not the hormones that's being released. Where is this in the slides? Oh, Gabrielle, I actually didn't write it down. I just, in my mind, when I talked about it in this slide here, if I had to put it, I would put it in this slide here. Thyroid being like a primary deficiency. anterior pituitary being the secondary deficiency and hypothalamus being the tertiary deficiency. But I didn't write a formal slide. I could and put it on here. That's more just so you understand the terminology. So in this case, talking about pituitary adenomas, if it's non-functioning, what we're really concerned about, again, is the mass effect, the amount of cells present. So the bitemporal, there's a term we're going to talk about, like a disorder that can happen from this, called bitemporal hemianopsia, which, if you think about the term, so bi meaning two, temporal, which is like your temporal, the sides here, hemi being half. So people actually losing half of their visions of eyesight, the temporal peripheral, their temporal peripheral vision. And this can occur because of a type of pituitary adenoma, specifically that's compressing the optic chiasm. And this is, again, an example of what a pituitary adenoma can do. And what we often see are non-functioning ones, which again is more of a problem with the mass of the tumor and not actually the hormones that come from it. Let's see here. So to rule out primary, if you suspect secondary endocrine, you would give the releasing hormone. And if you get elevation in the target hormone, then the target gland is okay, and the problem lays with the pituitary. Yeah, so good question. So we're going to talk more about like where that problem is coming from. Because if you release a hormone, right, and if you do get the expected feedback, then that means that that second layer up is communicating, is functioning. If you don't get the expected feedback, then that could be the problem in either secondary or tertiary up, right? The target gland, they're saying the primary one is okay, the problem would be then further up. Or if you give that hormone you're expected to give and you do get a response and there's still though a problem at the primary level, then you know it's a primary deficiency. What else is there? So pituitary adenoma, hypopituitarism occurs due to compression, meaning the normal pituitary tissue that's there functioning gets compressed by the mass of the pituitary adenoma, and that causes that normal tissue then to hypofunction. And then you start seeing symptoms of a hypofunctioning pituitary gland, which really depends on whatever the hormone is that's supposed to be released. But again, this is specific to pituitary adenomas, really distinguishing between hormone producing or non-functional. And then non-functional, thinking about that tumor and that compression. And functional tumors present with features based on, again, the hormones that's being produced. So if you're dealing more with a hormone issue with pituitary adenomas, you really think about like, well, what is being produced? Is it oxytocin? Is it whatever other hormones, which we're going to talk about today? Then those side effects of that hormone is what's going to be coming from this pituitary adenoma. So I mentioned the bitemporal hemianopsia, and that is actually labeled here as B, which again, it's where both sides, half of the sides of the temporal areas loses eyesight. And the example here is if the pituitary adenoma is compressing the optic chiasm, which is here. So this is just sort of a background, and I don't expect you to memorize this, but how vision works, right? If you guys know, when you see something, the way that your brain receives that is actually cross from the temporal field and the nasal field. So what you see here with the nasal field actually is brought in towards like that left side of the brain. Same thing medially goes to the exterior part. It crosses at the optic chiasm, and then it goes to your occipital cortex and is sort of processed. And that's how your body creates like the picture of what is being seen. I don't expect you really to memorize that portion. We're going to talk about neuro next week. But what I want you to take away from this is how the pituitary adenoma then affects eyesight. Because if there's a compression of that tumor at that the preaxial region is what it's called, that can actually distort eyesight because of where it crosses at the pituitary area and then prevents the proper reading at the occipital cortex, preventing then it actually changes someone's vision. So it's just an example of a side effect of an adenoma. And it's different, this slide has different disorders that can occur. Again, this is just an example of one that can happen at the optic chiasm. So let me just go back, give you guys some, I talked about just some basic principles and definitions we're going to get more into, and then we'll talk about some disorders. So the first disorder was here, the pituitary adenoma, right? So this benign tumor of the pituitary glands, okay? From that, you can have, and I mentioned hypopituitarism. So hypo meaning low, right? So it's low or insufficient production of hormones by the pituitary gland. And it's usually when it's more than 75% of the pituitary gland itself, the actual cells of it is lost. And I just mentioned that that can happen if there's a compression from the pituitary adenoma, right? But it can also happen in what's called craniopharyngioma that happens in children. In both cases, it's due to a mass effect or the actual tumor itself causing compression on the normal tissue. There could be bleeding, the apoplexy, into the adenoma itself, also causing a loss of functioning pituitary gland. Something, and then for anyone who's into midwifery, whichever, also when you get into like pediatrics, there's something called Sheehan syndrome. And this is specifically causing hypopituitarism, but it's related to pregnancies. And what's happening here is an infarction of the actual pituitary glands. When a woman is pregnant, their gland doubles in size, and women also increase their blood flow. The blood flow sometimes is not enough or it's not sufficient for a proper perfusion of the pituitary glands. And during childbirth, especially if there's a large amount of blood loss during childbirth, there could be more of an infarction incurred onto the pituitary gland. So the pituitary, again, is larger in size. It needs more blood. If more of that blood is lost, the pituitary gland goes into an infarction, and that causes what's called Sheehan syndrome, which again is an infarction of the pituitary gland causing hypopituitarism. And that shows as poor lactation, loss of pubic hair. It wouldn't be known initially that this happened to the woman during childbirth, but after, when symptoms occur, again, poor lactation, lack of pubic hair, fatigue, which if you've had birth, which obviously I have two, you feel this anyway. Like you feel fatigued. I don't know how much of people are actually looking at their pubic hair growth, right? I mean, we're nurses, we can talk about this. But poor lactation could just naturally also happen. So oftentimes if someone is not aggressive enough or looking into this, they might not initially realize this person has developed Sheehan syndrome. But again, hypopituitarism can happen after childbirth because of the infarction of the pituitary glands. Another form of hypopituitarism is actually more of a congenital defect when there's what's called an empty cella syndrome. What happens here is when there's a herniation of the arachnoid and cerebrospinal fluid into the cella, which is, I'm going to show you the part of the skull, the brain, and that compresses and destroys the pituitary gland. So in this case, this is a congenital defect within the cerebral functioning, and there's a herniation, the arachnoid comes in, cerebrospinal fluid builds up and destroys the pituitary gland. And when you look at this under radiation, like a radiology study, you actually would see on imaging what's called an empty cella, where you actually don't see the pituitary gland. It looks absent. I'll show you what a picture of that looks like. So here, so on the right, it shows where the optic chiasm is, where the cranial nerves come together. And here on the left, it shows what it looks like when it's sort of like emptied. And what that, there's a term for that, tunica sela, something, and it means like horse saddle or something like that. And so it was supposed, if you look at it, it sort of looks like a horse saddle. I don't know if you guys gone horseback riding. But if you compare the left and the right here, see the right, it's actually filled, right? Do you see where it says pituitary gland? That's what it's supposed to look like on the right. And if it's empty, that's what the green area here, because there's no actual pituitary gland present. Cella, it's like cella turnica or something. It means like empty or horse saddle or something like that. But that's sort of what it looks like, and that's what that means. And again, it's a congenital disorder. Okay, moving on to some other, these terms you might be more familiar with. ADH, I think we're all familiar. I think we talked about ADH when we talked about like bulimic statuses, right? So ADH, antidiuretic hormone, the person is meant to help you not pee. Everyone has this, right? This ADH and oxytocin are made in the hypothalamus and then it's transported via, of course, axons to the posterior pituitary for release. ADH, again, acts on the distal tubules, so it works on the kidneys, which I don't think we talked about much in the kidney lecture, I talk about it more when it deals with hypovolemia because it deals a lot with hypovolemic and hypervolemic statuses. But in ADH, the kidneys, it works with the kidneys to help collect and promote free water retention. And that's what's supposed to happen in the body. So we're going to talk about central diabetes insipidus and then, of course, inappropriate ADH. So if there is an ADH deficiency, and again, we're talking about this because it is within the endocrine system, so that's why ADH falls into this. If there's a deficiency, meaning you don't have enough ADH, the body's just going to pee freely and continuously. So this is due to hypothalamic or posterior pituitary pathology. So it could be due to a tumor, trauma. I don't know if you guys have seen this. I've seen it more for head traumas is when I've seen central diabetes insipidus. I know some of you work, I think, in neuro. So of course, this shows as features loss of free water. So the person's just continuously, they don't have enough ADH for retention. So polyuria, polydipsia, where it gets to the point where it's a life-threatening dehydration because of how much they're just releasing fluid. Internally, right? Think about that. If you're releasing all this fluid, you're then becoming internally very concentrated, right? You have no more fluid. So these people are hypernatremic, high serum osmolality. Their urine they're putting out, because it's so, there's that loss of free water, the urine is very, what? I sort of put here as low urine osmolality and specific. What does that mean? Like what in layman's terms? It's very diluted, exactly. So it's very diluted. So normally if you're testing their specific gravity, that would be a great test question, right? Because this sort of blends our renal lecture from a few weeks ago. What would you expect their specific gravity to be? Exactly, very low. Like give me a number. Very good. So one is the number one is the specific gravity of water. So exactly. So like 1.0058, something less than 10, barely like 10, 15 would be like on the lower end. So funny. So yeah, so specific gravity is 1, so something close to 1 is where these people would fall with an central diabetes insipidus. If you were to do what's called a water deprivation test, right? So water deprivation is exactly what it sounds like. So deprive the person of water, right? So they don't drink any water and you test their pee. So think about it. If you don't give them any water and you test their pee, if they didn't have diabetes insipidus, and let's say you just wanted to test it and their ADH is actually normal. If you were to deprive someone of water, then their urine should become what? Like any person. Right, exactly. More concentrated. Perfect, right, exactly. But if you do this to a person with central diabetes insipidus and you give them no water, so a water deprivation, right? They're like, oh my God, please give me some water. You're like, nope, sorry, your NPO, no water. Um, their urine would still remain diluted. And that's one a useful diagnosis or way to help to diagnose diabetes insipidus. The other way is also just testing the urine, because if it's close to 1 and it's continuously free fall, then you're dealing with central diabetes insipidus. And I don't know if you guys how your hospital diagnoses of this. You can also give the person desmopressin, which is similar to ADH, it's like an ADH analog. And if they respond to desmopressin, then you can also diagnose them with central diabetes insipidus. Normally, there's a tumor, trauma, like some other type of predisposing factor that caused the DH deficiency. That's another way to help with your diagnosis. A person can have what's called nephrogenic diabetes insipidus, and that's why we want to be specific versus central diabetes insipidus, because in nephrogenic, the person does have ADH. The problem is that the kidneys are not responding to the ADH, versus in central diabetes insipidus, there is no ADH. So I want to make sure the distinction between the two. In nephrogenic diabetes insipidus, this is due to inherited mutations or drugs or something like that. It could be due to lithium, which I don't know if anyone here works in psych. I've seen my share of patients getting lithium. Lithium can cause nephrogenic diabetes insipidus. There's also dimethyloxine, which again, I don't think that's as common, but these are known drugs that can cause nephrogenic diabetes insipidus. Clinical features are the same, though, pretty much as central diabetes insipidus. The problem here, though, is that they don't respond to desmopressin, right? Because the issue, again, is not the lack of ADH, it's the fact the kidneys are not responding to it. So I won't get into treatment of that, but of course, it would have to be some different, because kidneys are not functioning, they're not recognizing that. I would want you to at least to know both. I mean, the symptoms of both are the same, right? It's that polyuria, polydipsia. Just knowing the difference is that one has an ADH deficiency, which is central, versus nephrogenic, which makes sense, right? Nephrogenic, is that there is an impairment of renal functioning. And yeah, I think that would be important to know. In SIADH, when I always think about the word inappropriate, I always think like too much. Like if someone's like too much, you're being inappropriate. Too much too much ADH, right? So too much ADH where the person's not peeing at all. So excessive ADH secretion, usually again, it's due to some sort of, so ectopic meaning just somewhere else, right? It's not where it's supposed to be. It's not coming from the anatomical area of the body where it's supposed to be. So normally when you have ADH coming from the pituitary, it's controlled. If there's some other organism in the body, like cancer, this is an example we give a lot, in small cell carcinoma of the lungs, that could also be putting out its own hormones. One of those, it can help and cause a production of would be ADH. And that causes the person then to fall in SIADH. But you could also see this again in some sort of central nervous system trauma, infections, similar to what causes diabetes insipidus. But in this case, a person isn't peeing at all. So they become hyponatremic. So why is it hyponatremic if you're not peeing? Anyone remember the connection here from like a whole semester ago, earlier this semester? The connection, to think about that. Like, why would this person become hyponatremic? Exactly. They're internally being diluted. Exactly. It's not like they're losing sodium, right? They're actually the same. Sodium levels are pretty much the same. Perfect. But that retention is then causing them to become so diluted, they're becoming hyponatremic. They're low serum osmolality because the concentration is low. But that hyponatremia then causes mental status changes, right? As you should know about low sodium levels. It leads to neuronal swelling, cerebral edema, and that can lead to seizures. I don't know if anyone here has seen a seizure due to low sodium levels. It's a little scary. It's not something you could easily get them out of. It could take some serious medications like less than like what, 113, 115 sodium. Could be really concerning here. Okay. So let's move on from the pituitary glands. Thyroid glands. It's a lot of words here. Yeah, Zach. So you need to give them a lot of sodium, get that levels up, and then try to get them diuresed, right? Very good. So moving on from pituitary. A lot of words here. This really are just steps. This so if you guys remember from the liver lecture, I had like a lot of steps regarding bilirubin. Same thing here, a lot of steps for thyroid functioning. This is the picture of it. So either you like the picture or you like the words, or you could read the words with the picture, whatever works better for you for your understanding. Can you remind me why the sodium has to be increased slowly even if it's exactly. So because remember sodium moves with potassium. So if you move it too quickly, that could actually change cellular the osmolarity, and that could actually cause further swelling, herniation, and so forth. So you want to move your electrolytes slowly, because especially because potassium normally is intracellular, you're also moving that as well, and that could further actual damage if you do it too quickly. So yeah, you never want to, same, but anything else with the body too, like if someone is hypothermic, right? You want to warm them up slowly, like just always everything in the body, you want to move slowly, but especially when it comes to hydration, same thing, because those electrolytes and osmolytes also is moving as well. Thyroid, okay, where do we begin? So I like to go back and forth between the picture and so forth. In your thyroid glands, you need iodine, right? So you have your iodine. I'm going to go back and forth between pictures and here so you could follow along. So the iodine has this active transport out here. So this is like blood out here. And then this is the thyroid follicular cells, which make up your thyroid. There's an active transport of iodine going into the tissue. that's needed for thyroid functioning. So trapping of the iodine is mediated by TSH. So the thyroid stimulating hormone, TSH, is needed. It's needed in pretty much all functioning of the thyroid. But more specifically, initially, it's needed just to help in trapping that iodine coming in to the thyroid cell itself. If the thyroid stimulating hormone is not stimulating the thyroid, then the thyroid gland actually atrophies. You end up with, of course, hypothyroidism. Well, we're going to talk about the difference between hypo and hyperthyroidism. You could see TSH not stimulating the thyroid gland in hypopituitarism, which we talked about in certain disease processes. You'll see changes within the thyroid stimulating glands, but you do need that initially overall just to begin the process of bringing that iodine in. The term for bringing iodine into the thyroid system is called is oxidation of the iodine and changing from iodide to iodine. And that process of changing iodide to iodine is an enzyme called peroxidase. So thyroid peroxidase causes that conversion, and that is what's needed for the creation of what's called the MIT and DIT. So I'll just go back. So in the picture here, oh, where's my... Okay, so again, TSH is needed here in pulling in the iodine activity to the thyroid cells. It's brought on over here as TSH comes through, changing iodide, this one here, to iodine here. TSH and thyroid oxidase, the enzyme, then helps combine iodine, it says it up here, thyroid peroxidase, this enzyme, combines the thyroglobulin to iodine. That combination, bringing together the two, is called the oxidation, as I mentioned, but then it's called organification. And organification, again, is a combination of the iodine to the thyroglobulin, creating the thyroid hormone. So I'm just following along this picture here. Oh, I keep losing my mouse. Okay. So again, TSH mediates all of this. Oxidation of the iodide to iodine is mediated by peroxidase, the enzyme. Organification, again, is the iodine binding to the thyroglobulin, creating the thyroid hormone. Iodine is incorporated into tyrosine, which is tyrosine is a non-essential amino acid that's needed to combine with the iodine to form what's called the MIT and the DIT. And I always find this very interesting. The M in MIT stands for mono, which means one. So it's monoiodide tyrosine. And the D in the DIT is di, which stands for two, which I think you guys know the basics of that. So mono one, DIT two di, and the di is the diiodotriosine. So this combination is needed in the formation of T3, T4. So organification, again, is required, requires TSH for that process to form MIT and DIT. And this is important because it requires the coupling of MIT to DIT to create T3. Or if you have two DITs together, that's how we make T4. So I always think that's very interesting, that combination. So again, organification is iodine binding to tyrosine to make the MIT or a DIT. And then an MIT with a DIT makes T3, or two DITs together again makes T4. And that's how you get your basic thyroid hormones. How would this reflect in a test question? Good question. Let me go through it, then I'll think of a question for it. So again, that's how you make T3, T4. These hormones are stored as colloids within the thyroid cells. They're released within the blood, and that's why we check someone's thyroid levels. They're broken down by proteolysis with these enzymes called lysosomal proteases, again, also being TSH mediated. And these enzymes, the lysosomal proteases, is what releases the T3, T4 for use. When T3, T4 is released, they bind to TBG, which is the thyroid binding globulins. 1/3 of thyroglobulins sites are always occupied. So I'm going to show you a picture of that. So you have a thyroglobulin. T3, T4 is binding to the thyroglobulin. At any point, those binding sites, about 1/3 of them are always occupied by T3, T4. This is where you make a distinction when it does like lab results, because people are always, I don't know how much you guys read thyroid levels. Anytime a patient comes to me, they're like, oh, hypothyroid, I have a thyroid issue. They always only come with like TSH. I'm like, what am I supposed to do with this? And I always ask an endocrinologist, like, why they don't do more testing of T3, T4. Usually I only see a TSH, but it's important to test your T3, T4 because you can, sometimes your body's TSH does not, respond to an improper T3, T4. So I have patients who come and they're like, oh, I have a normal TSH. I don't have a thyroid issue. And I'm like, but you're sluggish, you're gaining weight, whatever that is. You test your T3, T4 and it's actually low. I'm like, well, do you see like your TSH wasn't responding? So things like that, it's important to, I always want to test, but also make sure you understand what you're testing for. So in a free T4, so FT4, that is peripherally converted to free T3 by an outer ring. And you don't have to know this enzyme, the deodenase. But what's important is that you know that free T3 is what's metabolically active. Free T4 is considered a prohormone, meaning it's like the precursor. You need T4 to convert to T3. So again, it's a free T3 that's the metabolically active, not the T4. And this is also important for you to know because you might see someone with, let's say, a normal T4, but a low T3. Well, that tells me then that the body is converting the T4 to the T3, right? Or you might see someone with, let's say, a normal TSH, but their T3 is low. Well, that's hypothyroidism, even though the TSH isn't responding. So understanding how to interpret the thyroid hormone levels, I think, this slide with the next pictures really helps you understand, like, why don't I really care about free T4? Why is a T4 elevated make more indicative to tell me about my T3 levels? What does that tell me about my TSH? Like, what does that mean? And I think overall, especially in primary care, you're going to see this time and time again. So knowing how to interpret it, is important. So free T4 and free T3 have a negative feedback relationship, as I mentioned, with TSH and TRH. So if they're low, it should be stimulating the TSH to be high and the TRH to be high. So again, a low T3, T4 needs to stimulate to raise TSH and TRH. So an increase in FT, the free T4, T3 should decrease the TSH, and a decrease in the T3, T4 should increase, right? So I always think of TSH, a thyroid stimulating hormone, sort of like being the friend to the TSH, to T3, T4, to say, hey, wake up, what's going on? Like I'm trying to stimulate you and wake you up, right? So if I'm working really hard, the TSH, it's because the T3, T4 is sleeping. Once T3, T4 wakes up, then I'm TSH, I can go back to sleep because now you're awake, you could do your job. So that's why it's always negative feedback, right? One should be working to get the other one working. And then once it is, then the other one could take a step back.
I have a question. The way it's written here, free T4 over free T3, do you
Don't read
read
it
this as
as
a
over.
ratio or does that mean or?
Just like write an increase into and or T3. It's like it's saying both. Maybe a comma would be better there. An increase in T4 and T3. So it's not a ratio. Here, let me do this. Is this better? A comma? Does that help?
Yeah, that's better. Just want to make sure it wasn't a ratio.
Yeah, it's not a ratio, it's not any math or anything. It's just meant to say that both the T4, T3 causes, the change versus T4, T3 also causes another change in TSH. So, okay, let's see how this would look in a question. So again, this is just a picture form of that, where thyroglobulin, again, binding to the iodine, coming together using thyroid peroxidase. Then coupling occurs, causing T3 and T4 development. It then goes back in through thyroglobulin endocytosis, where it gets back into the thyroid cells. And then the T3, T4, MIT, DIT get released through the thyroglobulin, and then through circulation, helping with metabolism and so forth. But it's pretty much, again, the reading should be the same as what you're really seeing here in this picture. In the slides I put up, I'll put up a new slide because I sort of redid this after I looked at them just to help with the understanding. The slide you have is this one, but it's actually two parts. And I thought breaking up the parts maybe would help with the understanding. So this again goes back to understanding what kind of lab values you would test and for what. Someone did ask about an exam question. I want to make sure your exam are relevant to what you're going to be seeing and not just about terminologies. I think it's important to know that TSH works within all of these practices, that you understand that T4 is the pro-hormone to T3. I'd probably end up asking you more about like lab questions, like a nurse sees a patient. I'll give you hints, like with complaining of constipation and weight gain and fatigue. The nurse notices the patient has, I can't say a number, right? So I would say like a TSH of like 7, which is high. And the nurse notices, let's say a high TSH and, I'm sure I'll give you anything tricky. Let's say a low T4, but does not see a T3 value. The nurse would expect the patient to be experiencing, and the answer would be, anyone know what the answer would be? If it's a high TSH, they're gaining weight, they're constipated. I don't know where my chat box is. Yep, hypothyroidism. To clarify, you need T4 to get to, exactly, you need T4. T4 converts to T3. And exactly, that's hypothyroidism. But I would make it like, not just hypothyroidism, like hypothyroidism. We could even make it like where the problem is with the pituitary, like at the thyroid sites. Or you could say, you can make it more complicated, right? So a nurse notices a patient has, trying to think about ask you something like that. Like a low TSH with a low T3, T4. And the person is still gaining weight and still constipated, right? If they have a low TSH and a low T3 and a T4, but they have the symptoms of hypothyroidism, I probably might ask a question to say, like, the nurse then gives the patient a synthetic TSH and then notices elevations in T3, T4. The nurse recognizes this is hypothyroidism at what level? And the answer would be like a secondary hypopituitarism because the TSH responded after you gave them TSH, a T3, T4 responded. Right? Oh yeah, you could say it's a tumor. You could say like, exactly, there's something else going on at a higher level. So thinking about it in that way. So the issue with that is not the issue TSH converting. So in the case where the TSH is low and T324 is low, the problem is that TSH is not raising its level to then stimulate T3T4's movement. So if there's TSH is not available or is not stimulated, that's another secondary or tertiary problem. It's not the problem of the thyroid itself. It's higher up, like a tumor, for instance. So I mean, when TSH, oh, my thing is in the way. When TSH is high, that normally means that T3, T4 should be low, right? So T3, T4 is low, and that's what's indicating TSH to go high. That's a negative feedback loop, which is then meant to stimulate T3, T4. That's what's supposed to happen. And the question I just gave, the example, and again, think about all the ways this could work. If your TSH is low and T3, T4 is also low, the person is showing signs of hypothyroidism, then something's going on. Why isn't TSH being stimulated? And it could be a hormone issue. It could be a tumor issue. It could be due to hypopituitarism. So maybe the pituitary isn't releasing TSH. So thinking about all those higher levels. If you already create T3 from MIT and DHT, then why does the body need T4 as a precursor? Good question. So normally in the process of it, you're going to have more T4 than T3, and you need the conversion of T4 into T3 to be active. So when your body doesn't produce usually enough T3 on its own. You need that T4 conversion of T4 to T3 to have proper thyroid functioning. That's a good question. But the body does create in the thyroglobulin T3 on its own with that MIT and DIT. Good, so you guys are following along. Again, either you love this stuff or you hate. I think it's so interesting. But again, that release of MIT, the DIT, and the T3, T4. So in this, again, I divided the picture up. It's the same thing. So this picture, I just divided it. So instead you have these two normal thyroglobulins. So I just divided it up so you see that part first here. So the same two normal thyroglobulins, and each one has T4 connected. And all this is saying here is that your T4 connected here is your FT4, right? Is your free versus your total is the number 10 here. So it says total T4 is 10. And the way we get that is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So if you were to do labs on this person, it's showing that the thyroid released T4 and you have a total of 10 T4s. However, what you need is the ones that are free. So the ones that are free are only 4. Do you guys see that? So that's why I divided it out so you could see what's happening here. So you have free 4 free T4s. They're free. They're not bound. And total is 10. And in this case, your TSH is normal because it's reading a normal value. Now, let's say in your next slide, those what I wanted to show is, let's say your body then produces another thyroglobulin, which can happen with like hormone changes, things like that. Your body will then take another 3 T4s and bind it to the thyroglobulin. The thyroid then will release another 3 to sort of make up for the 3 that was bound. So then what's your total amount of T4 now? Total. You would just count it, right? So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, it's 13. What this is showing is that these 3 from the thyroid came up here to bind to this thyroglobulin. So you have a total T4 now of 13. It went from 10 now to 13 because these extra 3. But how much free T4 do you have? You still only have the 4, right? Because the 3 that were produced bound to the thyroglobulin, you're still only left with 4 free T4s. That didn't change. And the reason this is important, again, is when you're doing lab results, people tend to like look at, thyroid, not know what they're looking at. Your total T4 really doesn't tell you anything, is what this slide really tells you. Your total doesn't tell you because it's bound. What tells you anything is the free T4. And as long as that's normal, your TSH is going to be normal. Your T3 should be normal. If it's when your free T4 changes is really what gives you more information as to what's happening, internally to the thyroid. But the total amount, because it's bound to thyroglobulin, doesn't actually change thyroid functioning. And again, there are some hormones that can make this different. Estrogen, actually, someone's on like estrogen replacement therapy, they can have higher amounts of thyroglobulin, which then would increase their total T4 count. But does that mean they're having like hyperthyroidism? No, it's a total amount, right? Versus if they have an elevated FT4, then you might start suspecting like, oh, maybe I'm dealing with hyperthyroidism here, right? So again, knowing the difference between total and a free is important. Okay. So in hyperthyroidism, I was just mentioning that, there's an increase in these circulating thyroid levels. So hyperthyroidism, think about the person's hyper, so everything is up. So increased basal metabolic rate, because there's increased synthesis of the sodium potassium, that ATPase enzyme. So from the mitochondria, so just increasing the metabolic rate overall, increasing the sympathetic nervous system. So these are people who have like palpitations and weight loss. And this is due to an increased expression of the beta-1 adrenergic receptors. Again, I don't really get it in that level with the nervous system, but knowing that your T3, T4 levels translates to metabolism and increased reactions within the sympathetic nervous system, causing signs of higher metabolism, such as, again, weight loss, heat intolerance, sweating, tachycardia, palpitations, I mentioned it. AFib, one of the first things to do when someone comes in with a new AFib, just check the thyroid levels. That could be a reason, especially in the elderly patients. New onset of anxiety, tremors, changes in menses, like infrequent menses, diarrhea, bone absorption issues. These people are going through sometimes like decreased muscle mass because their body circulation is changing and going more like a fight or flight mode. Because of the high metabolism, cholesterol is being eaten up or used more. So these people are experiencing more hypocholesterolemia. And then hyperglycemia, because again, their body's in fight or flight. So their body's trying to build up nutrients to survive and causing gluconeogenesis, glycogenization, which then causes hyperglycemia, right? Because there's that breakdown of glucose. So all of this is happening in hyperthyroidism. So if you think about like just upping the metabolism, right? That's how we see hyperthyroidism being clinically manifested. And one reason for hypothyroidism is an autoimmune disorder called Graves' disease, which I think is pretty common. It's, you know, it's not, it's seen usually in primary care. What's happening is immunoglobulin G as an autoantibody stimulates the TSH receptors, which is a type 2 hypersensitivity. You guys remember that from a few at this point, weeks ago, different types of hypersensitivity. So this is considered a type 2 hypersensitivity, again, where the immunoglobulin G is stimulating the TSH receptor. And by that stimulation is causing hyperthyroidism, leading to a chronic disease called Graves' disease. So this leads to increased synthesis and release of those thyroid hormones, and all the symptoms that I just talked about occurs usually in childbearing age. Hyperthyroidism, but usually because of this overstimulation, leading to a goiter, the thyroid goes through its hyperplastic and hypertrophic states, which then causes a goiter development. They can also have expothalamus and pretibial myxedema. I usually show a picture of expothalamus. But what's happening here is there are these fibroblast cells behind the orbits of the eyes, and they're also overlying on people's shins. And these fibroblasts actually express TSH receptors, which are being also hyperstimulated, which then can cause expothalamus and cause pretibial myxedema. That activation, that second bullet point really goes into more detail, results in an increase in chondroitin sulfate and hydroxyl acid. That term for the increase in those acids is called glycosaminoglycan. And that increase of those products from the overactivation of TSH is what then causes the exothalamus and the periaxial edema. When you look at it, it looks like a bulging of the eyes. The edema itself is really not really fluid, or it's almost like it feels like tissue. If you ever felt or palpated myxedema, it comes across almost like a fibrotic state for these patients. And it is reversible once if you treat the Graves' disease. In Graves' disease, so think about it, people are suffering from hyperthyroidism. So their T4 is going to be elevated, right? TSH is going to be low because it's sort of taking a step back, right? It doesn't have to be that negative feedback. Normally what we see is that T3 downregulates the TRH receptors in the anterior pituitary to decrease the TSH release. So again, it's that negative feedback where T3 is telling the TRH, which is the higher up in the hypothalamus, and telling the TSH to slow down. But even when it slows down, because of the overstimulation, it's still, the T4 is still elevated anyway. But you're going to see a decrease in T4 and TSH. Again, you're going to see the hypocholesterolemia, increased serum glucose, same reasons that I said before, with these patients are going to have that hyperstimulation from the antibodies. Okay, so that's Graves' disease. On the other end, you can have hypothyroidism, which I think we see more often. I gave some examples of that. In newborns, neonates, hypothyroidism, the term is creatinism, which I don't even know if they use that anymore. a cretin. They usually use that term like as like a bad term against a person, like someone who's like small in stature, a cretin, but I don't think that's an improper term, not I don't think used anymore. But if a person did suffer as a neonate or an infant from hypothyroidism, they normally were then would develop and born with mental delays, a short stature, not fully maybe develops their skeleton formation. Same thing where their facial features might not be fully or properly developed, enlarged tongues, and usually an umbilical hernia goes along with this. A thyroid hormone is required for normal brain and skeletal development. So depending on the treatment, again, I don't know, some of you do here work with children. I don't know if that's still, because normally they would catch this early on for treatment when the person is still in utero. Anyone see a baby born with hypothyroidism? Just curious. Um, my own personal story, when I was pregnant with my son, he was my first child, I actually ended up with hypothyroidism. I'm trying to how they caught that. And I actually had to take Synthroid, levothyroxine every morning. But then as soon as he was born, I got over it. It was very interesting. And he came out just fine. I mean, thank God I think they caught that. If not, then I think I might have been dealing with something like this. Oftentimes, it's maternal hypothyroidism that's not properly treated that can lead to cretinism in children. Why would serum glucose be high if metabolism is increasing? Good question. It's the metabolism is increasing, which is then causing the body to go into fight or flight mode. When your body's in a fight or flight mode, it breaks down the glucose held by the liver called glyconeogenesis, which then releases glucose into the system for the person to fight or flight, to run away from the lion, whatever that is. And by doing that, if you were to take their actual blood sugar, it would be elevated because of that breakdown of the glucose. You would think if you ran enough, eventually, right, you are going to see a decrease in that glucose levels. But overall, the thought is that the person's going to have high glucose levels because of that continuous breakdown of glucose at the liver. Emma, no, but in NICU, we test babies, TSH and T4. So if their mom, oh, Manuel, come, I was just talking about you. If their mom had a thyroid issue. So do you find, Emma, that after they're tested, the babies themselves are normal, like they have normal thyroid levels?
Yeah, usually they're normal, and we kind of have like an idea anyway if they're not presenting with like classic features like tachycardia, things like that.
They're not. The babies are
Yeah,
not.
no, they're
Okay.
not.
I was gonna show your face. They said that you came out normal after I took all that Synthroid while I was pregnant with you. Okay. No, I'm not downloading any games. Please. If you go over there, I'll download the game. Okay. So see, very normal and bothers me every day. Okay. So yeah, I mean, it was interesting to me because my mom, actually the endocrine, I always talk about to my mom because she passed away from thyroid cancer. It'll actually be 10 years this year. And so I'm always hyper paranoid that I'm going to end up with thyroid cancer. So I go see an endocrinologist for ultrasounds and they tested my lab. So when I ended up with hypothyroidism, with Emmanuel, they're like, oh, like you're going to end up with Hashimoto's like later on when you get older. And I actually tested positive for TPO. So every year now I go and get tested, but he's refusing to test my TPO again. He's like, oh, we already know that you have it. And I was like, no, like I think I'm fine. But right now, like, thank God my TSH, all that's normal. We see elevated TSH levels and have to recheck them in the primary care setting in newborns, but it's usually due to stress at birth. Stress on the baby causes elevated TSH levels. Oh, that's interesting. Oh, that's interesting. Okay, good to know. So yeah, I think and again, it's important, I think, this lecture because it doesn't matter what your specialty is, you're going to see thyroid issues. So just knowing how that means, how that relates to your patient and how to treat it or, expectations for the like symptoms is important. And again, the reason I brought myself up is because maternal hypothyroidism during early pregnancy can cause cretinism, but also thyroidogenesis. There is something called dysharmonogenic goiter, which is a goiter, which is the overdevelopment of the thyroid glands, but is due to genetic changes in thyroid hormones. That's another genetic disorder that could cause hypothyroidism, which actually because of the changes in thyroid hormone can then cause goiter development. Again, that's more congenital. And what's the other thing I was going to mention? Iodine deficiency can also cause hypothyroidism. That's not really so much of a problem in this country because we have iodine in like everything, right? The iodine are water and salts, and you find it in certain foods. I did hear though that RFK was going to change. I guess, did you guys? Sorry, I know I'm stressing you out. Okay, I won't bring it up. I just heard that they were going to change iodine levels because they didn't feel it was necessary. And I'm like, but I think our iodine levels is what keeps us from having a lot of these deficiencies, right? So I won't stress anyone out politically here, but that was what I just heard. Okay. Where am I? Okay, so we're talking about hypothyroidism in children, babies. And how that could come from, hypothyroidism in mothers. So in adults, so clinically features, again, same thing though, where hyperthyroidism, the person's really hype, they're tachycardic and just losing weight and so forth. And again, that's extreme textbook hyperthyroidism. In hypothyroidism, think about just everything's the opposite, right? So decreased sympathetic nervous system activity, decreased basal metabolic rates, causing weight gain. You could see myxedema, which again is that accumulation within the skin. They do say, which I have not seen, it could result in a deepening voice, a large tongue. Again, I would think that's really untreated, far gone hypothyroidism. I have not seen it in that way. As you know, I work in weight loss, so everyone comes to me with, they think they have hypothyroidism because, again, with the weight gain, but just fatigue, cloudy, they're not able to think clearly. Also comes with infrequent menses. In these cases, hypercholesteremia because again, that's low functioning. One thing I do though with cholesterol is, first off, is it fasting? This is more of me just as a clinician, what I tell my NP students when they come precept with me. When you get a cholesterol level, was it fasting? If it wasn't fasting, then I'm not even reading it as a true reading. If it was fasting, always also check the thyroid levels. If someone has hypothyroidism that's not controlled, or if they were not fasting labs, I wouldn't trust it. Fix the thyroid issue first, get a fasting lipid before you treat it. Because people with hypothyroidism could just have hypercholesteremia because of poor thyroid functioning. Same thing for constipation. Constipation is always like a thing. Everyone's like, oh, I'm constipated. But little like, how much water do you drink? Are you just not just hydration, but fiber intake and all of that? But then look at other functioning. What other medications are you on that could cause constipation? And then also checking thyroid levels. So you always want to say like, what other things need to be in order before you start making like start putting them on colace and laxatives? Well, no, like their thyroid functioning isn't normal. So treat this first, right? So always think about getting your patient in order before you start throwing medications at them. Again, so hypothyroidism, iodine deficiency, I mentioned, but also like for me, in this country, Hashimoto thyroiditis is considered the #1 cause for hypothyroidism. But also lithium could cause hypothyroidism. Surgical removal. So when my mom had thyroid cancer, they removed her thyroid, obviously, because of the cancer, which then put her in to hypothyroidism. So for any of these reasons, could cause hypothyroidism. Now, specifically for Hashimoto's thyroiditis, it is an autoimmune disorder where there's a destruction, where the body's actually destroying its own thyroid glands. So it's associated, we don't really get into the specifics of the autoimmune channel, but HLA-DR5, really the takeaway from this, it is an autoimmune disorder, destroying of the thyroid gland. And again, it's usually not connected to iodine deficiencies, again, which is why in this country, that's not really considered a concern. When you first check someone's labs, you might see elevated T3, T4 because the destruction of the thyroid gland, the follicles, actually releases the hormone. So you might see an elevation in this, but quickly it progresses to a decreased T3, T4 and an elevated TSH. And you'll actually see in the labs, positive antithyroglobulin and positive antithrombin peroxidase antibodies, which anytime a person comes in my practice, and I'm suspecting hypothyroidism, I always check a TPO and antithyroglobulin just because I want to say, like, is this actually just hypothyroidism or am I dealing with Hashimoto's? And because people are like, well, what's the distinction? The treatment and the symptoms are actually the same, but I always want to know if autoimmune is in my mind for this patient, like that they're prone to autoimmune disorders, because then you also want to think about like leaky gut and lupus and like there's all like rheumatoid arthritis, like there's so many other autoimmune disorders, and that's more of a rheumatology discussion, which I will not overwhelm you with in this class. But just knowing what the exact diagnosis you're dealing with is important. So if it just is a basic hypothyroidism, or is it actually an autoimmune disorder? Because also when you think about it, the person's immune system is actually fighting against itself. So the presentation of that's important. In Hashimoto's, it leads to chronic inflammation. And you have these specific cells, germinal centers, and these Hürthle cells, which you'll see actually, if you were to actually study the thyroid cells, you actually see this in the histology of it. It's actually a metaplastic eosinophilic cells that line the actual follicles of the thyroid that you could see actually under radiology study. But we don't do that. You get positive, you see a hypothyroidism, elevated TSH, positive TPO, positive antithrombin globulin bodies, you have Hashimoto's disease. We treat it the same, levothyroxine, well, I usually start like 100 micrograms on a empty stomach first thing in the morning, and we go from there. There is an increased risk for B-cell lymphoma, which a connection of I'm always reading the difference, which is related to the autoimmune disorder. It presents as an enlarging thyroid gland later on, disease course. Again, usually treated basically with just levothyroxine. Okay. Moving on from the thyroid. So I put this picture in here to talk about the adrenal cortex. You know what? What time do we start? Like 2 something? Let's take this like a 15-minute break real quick. I keep talking and I think my son is asking for something. I will be back, give it like 3:45 and we'll just get through it. The adrenal glands, I think that's actually it for today. Okay, so I'll see you back at 3:45.
Oh, actually, Professor, before you go, would
Yeah.
you mind going back real quick to, I think, one of the first slides on negative feedback loop?
Yeah, that's like the first slide.
Yeah, see, just in this example here for the negative feedback
Can
loop.
I ignore that example? Actually,
Yeah,
I'm
because
still
I'm like,
moving,
this
right?
order
I
seems
think
off.
it's such, right.
It's
So
worded
this
like
slide
wrong.
originally came from the previous, like I started teaching this course like 4 semesters ago. And every time I see some like students tend to like that. And I'm like, I don't think that's a good example.
Yeah, I think it's
So,
actually in the wrong order. Like it should be when there's an increase in the cortisol that provides negative feedback, which then lowers the ACTH, right?
okay. So I was with talking to another instructor, like, well, no, and they argued that this made sense. And I was like, I don't like in my,
Yeah,
what
like it
I'm
doesn't
saying,
make sense to me. It's like the wrong order to
increased
me.
cortisol would then decrease ACTH. That's what's supposed to happen in negative feedback. But I've had arguments against this example. So I was like, okay,
Okay, great.
yeah,
Just so
but
that we
I
like both
agree with
agree that this is
you.
like iffy.
Right. I agree with
Okay.
you that I think a better example is increase in serum cortisol would then decrease ACTH as a negative feedback mechanism.
Okay, great. Thank you.
Yeah. You know what? I'll probably clean this up and repost another, because I have other pictures in here just to help with understanding, but I completely agree with you. Every time I'm like, it's like a point of argument. So, okay, I'll see you guys at 3:45. So right before the break, one of your peers, who was it? Was it Sheehan, brought to my attention, which I had thought about, where is it? This slide. The example given here for the negative feedback loop, I agree with her because other faculty have argued the case that this example made sense to them as an example as a negative feedback loop. I thought it was confusing. So if you think it's confusing, go with what makes sense to you. What I liked it as an example for a negative feedback loop is when you increase cortisol levels and the negative feedback is to talk to the ACTH to come down, right? So that's the negative feedback. Or cortisol goes up, ACTH comes down. That's the example I'd like to give. I think that makes more sense in my mind. The other example I give is TSH being elevated, right? So when T3, T4 is low, it talks to TSH to go up. And then that feedback loop is then supposed to stimulate T3, 4 to go up, and then TSH goes down. So that's another example of a negative feedback loop. So thank you for bringing that up. Again, faculty have argued this case like, oh no, I think that's a really good example of a negative feedback loop. So I've left it there. If it makes sense to you and it works for you, great. Just want to make sure you understand, on the exam, I'm not going to ask you what's an example or defining negative feedback loop, but I might use it like in the term, like, maybe an example would be like a patient asks a nurse, why if the TSH was elevated, why is that hypothyroid? It's like something like that maybe, and the nurse would explain. Maybe that would be a way I could ask it in a question. Would insulin and blood sugar be another good example? Yeah, so like if blood sugar, well, how would that work? If blood sugar goes up, well, glucose, right? So glucose, yeah, levels go up, and or blood glucose goes down, then it shoots up like someone like glucose goes up, it would shoot up someone's insulin. Is that what you mean by that, Laura? Yeah, that could work. So yeah, it's just the way the body talks to each other. Because like, yeah, if insulin's down, that triggers you to eat, right? So then you eat, your glucose goes up, then that shoots up your insulin to then come down. Yeah, actually that works. That's perfect. So yeah, it's really just a concept of that. So awesome. We went from the pituitary and disorders in that, working our way down, so adenomas and so forth, and hyper disorders in that. Went down to the thyroid. What Laura I think is saying is when someone has a low glucose levels and that causes them to want to eat, they eat something, then that causes their insulin to be released, is pretty much, which if you think about what's one causing the other, it's more of a signaling, I think is the way to look at the glucose and insulin. So when you are when you eat, your glucose goes up, then that causes your insulin. They're not necessarily inverse, you're right, saying in that when someone's glucose goes up, that causes the insulin to go up. But initially, I think because it's low is a way you could think about it in that way. Or the thought is that if someone's insulin is down, that then triggers someone to eat, which then would increase their glucose level and then would cause their insulin to go up. You could think of that way as being, but they're not necessarily inverse of the way like TSH would be inverse on a lab value. I think that's what you're referring to. Like on a lab value for hypothyroidism, TSH would be high, T3, T4 would be low. And you're right in that. Glucose and insulin aren't in the same way. Okay. So yeah, the example I usually give are like the ACTH, the cortisol, thyroid. Those I think are good examples. In here, again, I just broke down this picture in your slides to this picture. So you have a breakdown of what's normal. And then what happens if you add another thyroglobulin. Really the takeaway in this is that your T4, even though it changes, your free T4 doesn't change. And that's why that's more of the lab to look at, because that the free T4 is what matters most in regards to functioning. So we talked about hypo, Hashimoto's. I gave you my own stories. And then we're going to end with adrenal cortex. And that's really all in regards to endocrine systems. When you get into your specialty, especially like maternity and all that, you'll get more into like lactation and oxytocin and all of that, which is a separate specialty in itself. There's some overlap next week with the neuro system. I will get into the renal and angiotensin system now, and that's pretty much, I think the details of for the endocrine system. Okay, so adrenal cortex, the adrenal glands, they sit on top of your kidneys, so there's two of them. I did add this picture in here so you know the difference of what I'm talking about. The adrenal cortex is this outer like yellow layer here. And then the medulla, which think about like middle medulla, is the middle part here, which we're going to get into at the end. But for now, there's a lot of issues that could happen with adrenal cortex, which I want to get into. So the adrenal cortex, 3 layers. There's the glomerulosa, fasciculata, and the reticularis. The glomerulosa releases mostly mineralocorticoids, which is like aldosterone. The second layer releases more glucocorticoids like cortisol. And the reticularis, we call them weak androgens, but thinking more like DHEA, which can relate to like testosterone. Okay. So cortical hormones are derived from cholesterol. So it's important that you understand the need for cholesterol and the breakdown of those hormones. I think people are always like, oh, like trying to reduce my cholesterol levels. But the understanding is you actually do need cholesterol to function in life. Like you don't want elevated amounts where it ends up plaquing, your arteries. At the same time, you need enough for these essential hormones. So, and the term here is sequential enzymatic modification, meaning you're taking these cholesterol levels, and through a sequence of enzymes, then breaks down and produces mineralocorticoids, glucocorticoids, and androgens. And that's really what that bullet point means. Sequential enzymatic modification. And that's, again, that breakdown of cholesterol. So each layer within the adrenal cortex secretes different types, again, as listed up here, based on the enzymes within that layer to create either, again, mineralocorticoids, glucocorticoids, or androgens. And that is what I'm showing here. So again, up here on the top left, you have cholesterol, and each of these enzymes break down efficiently into different needs and hormones. So I don't want you to have to memorize every single word on here. I think the breakdown would be cholesterol as the starting point, and the end point for lane 1 is aldosterone. Lane 2 is cortisol, and then lane 3 is DHEA, testosterone. So if you think about it, I think in that way, it's easier to digest. And then the main enzymes that you could have a problem with, we're going to get into that. And that's really I think the takeaway. So again, cholesterol, the end product, aldosterone, cortisol, testosterone, DHEA. And then there's about 3 enzymes in here I'd want you to know specifically. So let's talk about this first column here, cholesterol going down to aldosterone. In hyperaldosteronism, where you have too much aldosterone, if you think about what aldosterone does, these people present with hypertension, hypokalemia when they have too much of aldosterone, and metabolic alkalosis. So aldosterone itself increases absorption of sodium and secretion of potassium. It really works, supposed to be keeping your blood pressure normal. It works in the change in those electrolytes and hydrogen ions in the distal tubules. So it works in conjunction, aldosterone works in conjunction with your kidneys. Again, the distal tubules and the collecting ducts. Increased sodium expands plasma volume, and that can lead to hypertension in cases of excess aldosterone. So again, in excess aldosterone, you have increased sodium, and of course, water goes where salt goes, right? So wherever that goes, salt is there, increasing, expanding the volume, that leads to hypertension. There could be primary and secondary hyperaldosteronism. So in primary hyperaldosteronism, it's most commonly due to bilateral adrenal hyperplasia. So you actually have on both sides, those adrenal glands are hyperplastic, they're growing, and that's in usual cases in primary hyperaldosteronism. In some cases, it could be adrenal adenoma, which is called Conn syndrome. And very rarely is it actual cancer, adrenal carcinoma. So again, either it's a bilateral overgrowth hyperplasia, or in some other cases, Conn syndrome, which is that adrenal adenoma. Again, that benign tumor growth. And very rarely is it cancerous. In any case, though, any of these could cause an increase in aldosteronism primarily, and it's usually seen through a CT scan to determine the pathology. Treatment for bilateral adrenal hyperplasia is a mineralocorticoid receptor antagonist, which I've seen. I've had maybe out of my thousands of patients, I've seen 2 have come in and they've been on spironolactone. And I'm like, oh, that's so weird for like blood pressure management. And they're like, oh no, I have an issue with my aldosterone. I'm like, that's so interesting, right? So to see that connection, I see also spironolactone, just more of a side note for, I've started using it for treatment of cystic acne, which has been actually also really helpful because it helps on that hormonal layer. So spironolactone, you know, it's potassium sparing diuretic, but it is also a mineral receptor antagonist. And by doing that, it helps bring down that hyperaldosteronism and prevents the hypertension. In that way, so people think it's more like as a diuretic, but no, it actually works as an antagonist. If it is an adenoma, like an actual tumor or a cancerous tumor, like a carcinoma, it has to be actually surgically removed. In secondary hyperaldosteronism, that comes from the activation of the renin-angiotensin system. So if you think about, kidney functioning, I think we talked about there's always an overlap when it comes to like kidneys and then the circulation, cardiovascular system. I bring up the renin-angiotensin system. So if you remember that and how that plays, which I guess we can get into more detail about the renin-angiotensin system, but that's the system needed to control blood pressure, but then also causes hypertension. So in both cases, you would see hypertension. The distinction really between primary and secondary is how a person actually presents. So if it is primary, you're not actually going to see a problem with their renin in their plasma, and you're not going to see so much edema just because the way that aldosterone circulates is not going to cause edema within the system versus because of the way the sodium releases, it doesn't cause edema. In secondary hyperaldosteronism, because it's affecting the renin-angiotensin system, the sodium retention in that actually does lead to edema, which is actually that could be pitting edema. And it could also, when you do the lab values, you actually would see elevated renin within the plasma. So that's how you know primary versus secondary aldosteronism. And then again, with a CT scan, you would see actually the bilateral growth above on the adrenal glands. So again, that's showing cholesterol coming down to aldosterone and then hyperaldosteronism from that. In hypercorticolism, also known as Cushing's syndrome. So Cushing's syndrome, the term really just means any disease process that causes high cortisol levels. That's all that means. There could be different diseases happening that can cause high cortisol levels, but the term Cushing's syndrome really just means any of these things causing the syndrome related to excess cortisol. So when you see too much cortisol, think about again what cortisol does. It's really that meant to keep you running, fight or flights. But long term, right, if someone has too much cortisol for a long period of time, you can't run from a lion forever, right? You can't be in this hyper survival state forever. Your body starts to break down from that. So you end up seeing muscle weakness, thin extremities, because cortisol is actually breaking down the muscle because your body feels it needs the muscle, those amino acids for gluconeogenesis. And I think who was Corey, like someone was asking about that glucose, your body's continuously trying to break down because of its survival mode, wherever it could find glucose options. So amino acids is one of those ways. So it breaks down muscle for that, but that then leads to muscle weakness and thin extremities. Because of the high glucose, though, then you also end up with high insulin levels, which I think was who was mentioning it in the Ting, I think was mentioning the relationship. When someone does have high glucose, eventually they're going to also have high insulin. I think that was what you're talking about, that relationship, because that insulin is needed to continuously try to break down the glucose. But insulin is known as a fat storage, right? So if someone is in that, again, fight or flight mode and they're breaking up that glucose to survive, insulin is also going to be present to help with that survival. So where does fat build up? Truncal obesity, that classic buffalo hump. I did see the moon face. I think it was it Amy? What's the comedian's name? She's very inappropriate. What's her name? Amy. I forgot her name. But she came out, I think that she had.
Amy Schumer.
Thank you. I think she said something bad against nurses, so I probably was trying to block her out of my mind. But I read that she was suffering from, I think, Cushing's disease or something, and that she had was suffering from a moon face. Something else is abdominal striae. So you have these impaired collagen synthesis resulting in thinning of skin. Again, that's more so related to cortisol breakdown and that creation of the collagen synthesis. And then hypertension, often with hypokalemia, with metabolic alkalosis, also coming from excess cortisol. Increases the sensitivity of peripheral vessels to catecholamines. So that could also affect, we're going to talk about catecholamines in a second, but affects the vasculature, causing hypertension at very high levels. Cortisol cross-reacts with mineralocorticoid receptors. So that really just goes back to the slide here, where it's saying that a high levels here of cortisol in the middle can actually cross and affect this pathway here, which then can affect aldosterone, but normally you don't see levels change of aldosterone Thank you guys for Schumer. I lost my chat box for a second. When you're finished, can you get some more? Yes, potential questions, definitely. And also because your body again is breaking down, you could end up with breakdown of the bones, which leads to osteoporosis. And as we know, when you're highly stressed, you are more prone to diseases. So a suppression of the immune system. So again, when you're in a fight or flight mode, high cholesterol, it's like you have this hand coming, just tapping me on my shoulder. You end up with disease process, just more prone because of decreased immune system. Okay. Before I get into this, let me just see about questions. A patient comes in maybe on spironolactone and recently diagnosed hypertension. The nurse notices maybe elevated aldosterone, or you might say like new onset hypertension, low hypokalemia, and on spironolactone. The nurse would expect which possible diagnosis, and the answer would be like primary aldosteronism, or it could be even bilateral adrenal hyperplasia would be an answer, because you know that they're on spironolactone. So I'm thinking that it can't be secondary hyperaldosteronism. Now, the hypertension could be primary or secondary. So we would need something to distinguish primary versus secondary. Or maybe I would then put they have low renin levels. So that would be a way to distinguish between primary and secondary. Trying to think what else. A nurse notices a patient had a recent CT scan showing adrenal adenoma. I think that makes sense. The nurse understands this patient probably is exhibiting, right? So you should know, hopefully, the adrenal adenoma, right, presents with, I think that makes sense, excess aldosterone levels. So the answer choice could be like excess aldosterone or hypercholesterol or cortisol or hypocortisol or hypertestosterone. So knowing where you would find adrenal adenoma as a problem, which is the adrenal glands, and that relates specifically to aldosterone, I think would be the one to get that answer correct. Let's see. For cortisol, let's see. Maybe something like just how a patient presents, which I think that would be an easy question. If I put like a patient presents with moon face, buffalo hump, and truncal obesity, the nurse would expect, I think that'd be way too easy as a question. I would probably be more like, the nurse would expect, something that you'd have to know that is Cushing syndrome without me writing down Cushing syndrome. Like the nurse would expect what level of cortisol, and the answer would be like elevated cortisol, right? Or something like that. But again, I think if I just put Cushing syndrome, that'd be way too easy of a question. Can it be easy? This is true. Maybe like a few easy questions, but I feel like that's gonna be when professors write questions, you're always looking for your exam to have like a nice like bell curve. And I think that kind of question would be like everyone would get it right, and then professors don't, well, faculty will look at you like, oh, you wrote too easy of a question. Okay, I'm gonna come up with some more questions. Okay, this chart. When you're what's the word I'm looking for? Interpreting adrenal cortex disorders. This is sort of like the breakdown of it and sort of different possibilities. So you could have on the left these causes. So it could be due to exogenous glucocorticoids, like someone who's getting glucocorticoids, maybe like asthma, right? I give a lot of steroids when someone has like asthma exacerbation. It could be due to an ACTH secreting pituitary adenoma, which is in 70% of Cushing disease cases, like especially in disease syndromes, someone could have an ACTH secreting adenoma causing elevation in ACTH. So again, that's a pituitary adenoma. Or they could have an ectopic ACTH secretion, meaning they have like a tumor somewhere else. A common example of this is small cell lung cancer that's known to secrete ACTH, and that's considered ectopic, right? So that's a place outside of normal where it's supposed to be in the body. That could be a cause for elevated ACTH, or a primary adrenal adenoma, which is like a hyperplastic disorder where the person could actually have like an adenoma, a benign tumor growth on the adrenal gland. So these are all reasons for some sort of adrenal cortex disorder. So either they have an elevated cortisol or an elevated ACTH level. But again, the ones here on the left are really the reasons for that. So the way to really know the difference, I really look at it in which ones are ACTH dependent and which ones are ACTH independent. And there's different ways, I guess, you could interpret or read the slide. It's really whatever works easiest for you. So I always think of the exogenous glucocorticoids and the primary adrenal adenoma. Those are reasons where you're going to see really low ACTH when you draw someone's labs. And those are considered ACTH independent. You really don't see ACTH related to those problems. Versus an ACTH secreting a pituitary adenoma or an ectopic ACTH secreting like tumor, those are considered ACTH dependent, meaning those are disease processes that are related to elevated ACTH. Okay, so again, these are all possible reasons to see problems with the adrenal cortex, but again, dividing it sort of in this way, and again, when you're studying on your own, think about a way that works for you. But I always divide exogenous as they're independent of ACTH, and the ACTH secreting are the ones that are ACTH dependent. So when you read this chart and you're thinking like someone is having some sort of a cortisol disorder, thinking like these four are like the reasons I'm thinking like, what could it be? So normally what I would do is I would test their cortisol levels and I would also test their ACTH. Normally when you test someone's cortisol levels initially, you know, like, okay, there is an adrenal cortex issue here. What exactly the problem is, we don't know. So we would normally do a low dose dexamethasone, this is on the next slide, test just to see if the body reacts to the suppression test. So let me actually go to that slide. I'll come back to this one. So in hypercortisolism, so in Cushing's syndrome, if someone has elevated cortisol, so the way we test cortisol, it's not just like a simple blood one-time randomized, it's not considered accurate. The recommendation is a 24-hour urine cortisol level or a late night salivary cortisol level randomized. And some states don't allow that. So depending on the state you're on, usually in the hospital, we do a 24-hour urine cortisol level. So if it comes back elevated the next day or whatever, you would do then a low dose dexamethasone suppression test. And what you would hope to find, so again, going back to suppression test, right? If I give you a low dose dexamethasone pill, it's a pill you would take, and I know that you have had previously elevated cortisol levels, if you take that dexamethasone at a certain level, then your ACTH then should, if it's responding normally, your ACTH would do what? Go up or down, if it's supposed to be responding properly. So again, your cortisol is elevated. I give the person a low dose dexamethasone. In a normal functioning person, that ACTH then, if it responds properly, should go up or down. Perfect. It should lower it. Yes, because that's a negative feedback, right? So I'm giving cortisol. It goes up to a certain level. It's supposed to then trigger negative feedback to the ACTH for the ACTH to then come down. Okay, which I think is what I said the next bullet point, right? So low dose dexamethasone suppresses cortisol in normal individuals, right? So it's supposed to then ACTH comes down, which then triggers the cortisol to also then come down, right? Think about the feedback. This goes up, it triggers this one to come down. ACTH then talks to cortisol to also come down. If it fails to suppress cortisol, then I know there's some sort of disconnect, right? Something is not talking to something else. And oftentimes in Cushing's syndrome, there is that disconnect, which then leads me back again to this slide. So let's say I do this test, right? And the cortisol levels don't change. I would then look at the ACTH levels, right? If ACTH is low, then I'm either dealing with exogenous glucocorticoids or primary adrenal adenoma. Normally, I mean, unless someone's injecting you in the middle of the night and you don't know it, you're going to know if you're on exogenous glucocorticoids. It's not going to be that hard to tell because it's something that you're actually going to have to be taking. And again, my example in this is I usually use that like some long-term steroid use. If you were to do an imaging study on this person, their adrenal cortex though would be bilaterally would be atrophied. Do you know why that would be? If someone's getting exogenous glucocorticoids long term, why would their adrenal cortexes be atrophied? Pretty much like everything else in the body, right? Like your muscles, anything. Exactly, you're not using it. Perfect, underuse. So usually it's your adrenal cortex which releases that cortisol, that steroids to use. If you're getting exogenously, meaning like an outside source, then your body's like, well, I guess you don't need me. So what is it going to do? It's like, well, then I'm going to go to sleep. So, and it goes to sleep, it atrophies, it's not being used. And we're going to talk about Addison's disease and what can come from that. Or in more rare cases, the person could have a primary adrenal adenoma where the ACTH is low. But in that case, we're going to talk about how that leads to imaging and the adenoma there. But again, normally it's exogenous and you know the person's on something exteriorly, or you see these elevated cortisol levels, you do an imaging study, you're going to see that they have this adenoma. Now, let's say you do ACTH levels and they're high. So, and we put like one arrow, so it's sort of high in ACTH versus in an ectopic, it's very elevated. Textbook wise, yeah, but in reality, like elevated is elevated. You're going to see high levels in both cases. The difference in this is if it's in the suppression test. Here, then you would move on to a high dose dexamethasone testing. So you give this person a high level dexamethasone, same idea though. You give them a high level of cortisol, right? If this is an ACTH secreting pituitary adenoma, but it's functioning, meaning the body's communicating, that pituitary gland is still going to recognize that high dose dexamethasone and it's going to do what? It's going to respond. It's going to become suppressed. There's going to be suppression of the ACTH because it recognized the high dose dexamethasone. It's like, oh, it's communicating, it's there, it's functioning, it's going to decrease in its production. Compared to if you give high dose dexamethasone and this person has to take cancer, like small cell lung cancer, and that small cell lung cancer is putting out ACTH. Is that cancer tumor cell going to respond to my high dose dexamethasone? It's not. It's not part of my endocrine system. It doesn't care that I'm giving high dose dex. It's not going to respond as a negative feedback loop. So even though I gave high dose dex, because it's ectopic, it's not part of my endocrine system, it's a tumor, it's cancer, whatever it is not going to respond by suppressing the ACTH. So in these cases, you give a person a high dose dexamethasone, in an ectopic ACTH, it's going to continue releasing ACTH. It's not going to stop. There's no suppression of ACTH in this case. So that's a test you could do secondary to tell the differences between a secreting pituitary adenoma versus an ectopic cancerous secreting ACTH. And again, in imaging of that, you'll actually see the pituitary adenoma. Or if it's cancer, if you do even like an X-ray or a CT, you're going to see CSLC as small cell lung cancer. And that's an example of an ectopic source of the ACTH. Okay. Trying to think, is there anything or a question to put this in? Let's say a patient comes in with high cortisol levels. The nurse sees that the patient is ordered to receive a high dose dexamethasone suppression test. after the test results, suppression is noted. The nurse would expect this patient to be diagnosed. The nurse would expect to find what on imaging? So if they do a suppression test, a high dose dex test, very good, a pituitary adenoma, exactly. The nurse would expect, if suppression occurred, the nurse would expect a pituitary adenoma on imaging. Okay. I know this, we're just learning once you go through, then, you could go through and then ask yourself these questions again. I'll try to put them out as practice questions. Now in the primary adrenal adenoma, there is high cortisol levels seen in this. The ACTH is not considered elevated, but there is a hyperplastic formation of one of the adrenal gland. And normally it's one-sided it's one side that's hyperplastic. And if you were to do an imaging of this, you actually would see an adenoma or carcinoma on one adrenal gland. But then the other adrenal gland usually is the contralateral called side is actually atrophied. The same reason that you have a bilateral atrophy up here. If one adrenal gland's working really hard, the other one's like, well, you don't need me. So same thing, it atrophied. And that's what you end up seeing in imaging. Okay, let's wrap up with adrenal cortex. In so this is a slide I was just talking about when you have elevated cortisol levels. Again, you're going to do that low dose dex suppression test to see if it responds. The normal thing is if there is really no other underlying issues, it should respond in a normal individual. However, if it doesn't respond, you then go forward with ACTH and see if it's independent or dependent. And if it's independent, you would do a CT scan and find if there's an adrenal lesion. If it's dependent, then do the high dose dex test and see if you see suppression or lack of suppression. Are they difficult? I guess because it's our first time going through it. I'm hoping if you study it and go back to the lecture, then hopefully it makes sense. I do think hearing it the first time, it is difficult to process. But what you want to do is first do that low dose dex, find out is it a normal, is the body processing it, cortisol normally? If not, then do the ACTH and then find out, is ACTH then causing a suppression or not? Those are the steps I would go through. And again, you sort of have to think that through, like that process and why you would do that or what you would expect to find. High dose dexamethasone suppresses ACTH production. Because if you think about it, the pituitary adenoma is part of the endocrine system. It's going to respond if it's functioning to that ACTH, right? To the cortisol and the ACTH production. But if it's not suppressed, then that ACTH is coming from another source that's not part of the endocrine system. So even if you give someone a high dex cortisol level, the ACTH production is not going to change. So again, think about it in that way. I'll try to come up with another question. Hopefully that might help. Okay. Congenital adrenal hyperplasia. So I just mentioned this on the previous slide here. This adrenal, something, there could be a hyperplasia, but if it's congenital and the person is born with this, it's usually due to some sort of enzymatic defect, so some sort of enzyme in cortisol production. Usually it's autosomal recessive. So you have high ACTH, and that high ACTH, especially this is congenital, remember it's a genetic disorder, leads to both adrenal glands having bilateral hyperplasia. Because again, you have high ACTH leading to think about that picture early on, high CH going down to the cortisol levels, causing an increase in cortisol, which then is supposed to then, remember, negative feedback, go back up to turn off that ACTH. Because there's an enzymatic defect in cortisol production, this person's going to have high elevated levels of cortisol. Mineralocorticoids and androgens may be also increased or decreased. That really depends on the enzyme defect, and that goes back to the cascade that I was showing before. So I think I have a picture of that here. Okay. So what I'm referring to is you have, again, cholesterol here going through this desmolase enzyme, which again, I'm not going to test you about the specific enzyme, desmolase specifically, but the enzyme going and breaking down this way to the 21 hydroxylase, the 11 hydroxylase leading to cortisol. When there's an enzyme breakdown here, that can really affect the production of cortisol and increase cortisol production, which then can affect and sort of carry on over to enzyme production of testosterone, androgens, and aldosterone. So more specifically, this goes into congenital defects, which again, if you work with babies, you might see this more often, other types of enzymatic deficiencies. So the ones I want you to know are highlighted here. There's a 21 hydroxylase, 11 hydroxylase, and then 17 hydroxylase. So those three, 21, 11, and 17. And that's because we actually test for these in the hospital. So 21 hydroxylase deficiency is the most common cause. So if you look at it here, this is 21 hydroxylase enzyme. So if someone were had this as a deficiency, when cholesterol breaks down, it would get down to progesterone, but then normally because this 21 hydroxylase is missing, everything gets shunted over and this person then creates more testosterone and more androgen, and they have less cortisol and less aldosterone. So if you think about that slide, and again, go ahead. Oh, is there a question? So as I mentioned, aldosterone and cortisol are decreased, and all of that makeup then goes towards, it's called steroidogenesis. It's shunted towards the androgens because that's what's the 21 hydroxylase enzyme is not needed for androgen. So that's why all the creation of steroids then moves towards that because it has the enzymes that's needed for that creation. Normally in this case, if you think about it, the person is missing cortisol and aldosterone. So the classic form presents in neonates as hyponatremic, hyperkalemic with life-threatening hypotension, again, because of the changes within the aldosterone system. The females have a clitoral enlargement because everything was shifted over to more androgen and testosterone. So we call that genital ambiguity when the child is born with a 21 hydroxylase deficiency. The non-classic form is stated textbook to present later in life with androgen excess leading to precocious puberty in males, hirsutism with menstrual irregularities in females. That could happen as a non-classic form labor, but normally if it's congenital and happens at during fetal development, you end up with this genital ambiguity and more of that hyponatremia and hyperkalemia, again because of that lack of the I won't say aldosterone. Yeah, the aldosterone makeup. So that's what specifically the 21 hydroxylase enzyme deficiency, which you see up here. And again, when this is missing, you could write like an X, like you're not going to get the cortisol and aldosterone development. In the 11 hydroxylase deficiency, so if you look at where 11 is here, same kind of similar issues where you're going to end up again with low cortisol and aldosterone because of the lack of the enzyme. And again, there's going to be more of that shunting towards the testosterone and testosterone and androgen formation. And you're going to end up with, again, clitoral enlargement and changes there because of that hormone difference. Here, because it's the 11 hydroxylase deficiency, that could lead to, again, not just androgen excess, but there is known to have weak mineralocorticoid DOC increasing. So the DOC is a deoxycorticosterone, which is more on the aldosterone.
Don't do that. Don't do that.
The aldosterone system. So that could lead to hypertension, sodium retention, mild hypokalemia, renin and aldosterone are considered low. So look at here, let me bring the slide back again. So when you think about 21 and 11 hydroxylase enzymes, really thinking of how that shunts over to the androgen testosterone system and how that changes, like, again, the ambiguity and puberty, cultural enlargement, and so forth. The real only difference is in the 11-hydroxylase, you have more of these deoxy corticosterone, which then you see some of that mineralocorticoid development coming through, which then makes changes to hypertension and sodium retention. So you see more of those aldosterone effects with 11-hydroxylase deficiency. Okay. And then lastly is the 17-hydroxylase deficiency, which I would think if you work with children, right, a lot of you probably do this testing. I don't know if what they term it, but this leads to decreased cortisol and androgens. Same thing though, where you have the DOC mineralocorticoids increased. Where again, with these children with this congenital adrenal hyperplasia, you're going to see increased levels leading to hypertension, mild hypokalemia. Renin and aldosterone are low because, again, they're missing the 17-hydroxylase deficiency. Decreased androgens leads to primary amenorrhea, lack of pubic hair in females. So if you think where 17 is, that's this deficiency, right? So if you have this lack there of here, you end up more with the you lose the androgen testosterone formation and you have more of the aldosterone formation. So thinking about, again, where the enzyme fits in the scheme and how that affects the steroid development. So in this case, again, decreased androgens because of the deficiency of 17-hydroxylase. Because of that, there's going to be, again, primary amenorrhea, lack of the pubic hair, ambiguous genitalia, or undescended testes in males because of this missing enzyme. In children, we do test for congenital adrenal hyperplasia through the 17-hydroxyprogesterone. And I think that is routine still. Anyone still with neonates testing for this deficiency? I know when I've taught this class before, the students told me they are still testing for the 17-hydroxylase deficiency. And that will tell you that there is a congenital adrenal hyperplasia, but then also the expected presentation of the children with, especially like undescended testes, amenorrhea later, things like that, that's expected. You would see in the 17-hydroxyprogesterone, if you do the testing, increase in 21 and 11 hydroxylase deficiency, and decreased in the 17-hydroxylase deficiency if you were to do this routine screening. And the treatment for any of these congenital adrenal hyperplasias, depending on what the deficiency is, would be a mineralocorticoid. You're pretty much giving what's needed. It could be a sex steroid if that's needed, or glucocorticoid. So you're really giving the child whatever is congenital, whatever's missing from the enzyme. You know, if it's a mineralocorticoid, glucocorticoid, or if it's a sex steroid. Wild aldosterone is low in 17-hydroxylase. Aldosterone is low. Androgen should be low. I don't think aldosterone should be low. Does it say aldosterone? So in the 17-hydroxylase, because the 17-hydroxylase is here, you're not going to shunt and have the androgen here in the testosterone. It's going to, you're going to have more aldosterone. Sorry, where are you seeing this? Oh, decreased androgens. Let me see here. You're going to have decreased androgen because of the 17-hydroxylase deficiency. Are you saying, Gabrielle, you're saying no, it is androgens, not aldosterone?
Right. I'm saying it's correct.
Okay, thank you. So yeah, you're going to have decreased androgen because of where it is on, here, you're missing the androgen. You're going to have more of the aldosterone. Okay, thank you for that. Where am I? So we talked about the deficiencies that you would see with adrenal cortex. And again, understanding really where the enzymes are and where that shunting is. You don't have to remember all these slides here, but just 17, 21, and 11. Aldosterone, if you want to write it out for the exam, I think that might help. So you want to have 3 lines: aldosterone, cortisol, testosterone, androgen, and then the 17, 21, and 11. And then hopefully I think that should give you the understanding of what affects what if you're missing which enzyme.
Are you saying that you want us to write out that whole,
I would
whatever that
write
is,
down,
equation?
I would write
I don't
down
even know what to call
cholesterol
this.
and then 3 lines and have aldosterone, cortisol, and testosterone / like androgen. And I think having it understanding it that way, I mean, you don't have to do it that way, but that's how I would remember it. And then knowing where all the enzymes are and sort of, so you understand the cascade. But I think those are the 3 things you just need to remember: aldosterone, cortisol, and androgen.
But then you have to remember what arrows are pointing to what and how that affects. I don't know.
Oh, I don't think you have to know
I'm
all
gonna
of
take an
that.
L on these questions. I have no idea.
Well, don't take the L now. I think, here, let me, what I was saying was for the purpose of understanding, let me see if I could. For the purpose of understanding, I was just saying that I think if you wrote like cholesterol here, you guys could see this, and then I would just write down 3 lines. When I think about deficiencies, this is how I do it. And then this would be aldosterone. And then this would be cortisol. And then this would be like my testosterone. Oh Lord, what just happened to my writing? This would be my testosterone and my androgen. And then I would write down my enzyme deficiencies. So 11, 20, 17, sorry, 17, 11, and 21 and 11. And then knowing like, okay, if this gets, is missing, then I'm gonna have more aldosterone and cortisol. Or if I have 21 missing, then this is all gonna be shunted over here. I'm gonna have more testosterone. So the words in between, I wouldn't worry about so much, but more like where the shunting is occurring based on the enzyme, based on which enzymes are missing. That's all. And again, I think taking it on your own time to see where those deficiencies are, hopefully would make more sense. I don't go, there's 10 questions, maybe 1 or 2 would come from something like this. I wouldn't go too hard on it. Let's see here. Oh, okay, I was sharing the slide. So that's how again, I wouldn't do the details of these questions. I would just remember the 17, 21, 11. And then if I'm missing 17, then it shunts down to aldosteronism, things like that. Yeah, like 2 of the questions out of the 10 from maybe the slide, like 1 or 2 of the questions to understand the deficiencies of these enzymes. Because mostly because I know if you're going to deal with children, this is a possibility of what you might come across. And just understanding hormone deficiencies and within the adrenal system is important. Okay, so adrenal insufficiency. This is a deficiency of adrenal hormones altogether. So acute insufficiency presents as weakness, shock. So meaning you don't have these adrenal like hormones, like cortisol hormones. So abrupt withdrawal, like so let's say someone is on a steroid long term and is abruptly withdrawn, they don't take their medication. It could be done within a treatment of Cushing's syndrome. It could also be in what's called Waterhouse, this hydrogen syndrome, Hydrogen syndrome, where there's this hemorrhagic necrosis of the adrenal glands. Again, that's more of a rare case. And the times I've seen this is what we call really like Addison's disease. In a more acute state, if there's just an abrupt withdrawal of someone's glucocorticoids, they didn't take their steroids, or in a treatment of Cushing's syndrome, where they're not getting their steroids, you end up with weakness and shock, which could be treated as long as you put back those missing steroids. In the case of this Waterhouse syndrome, this is usually due to some sort of sepsis, or if there's like some sort of meningitis infection in children leading to DIC. That DIC could then also lead to this Waterhouse syndrome. Again, that's very rare, where this the hemorrhagic necrosis leads to adrenal insufficiency, but it can, and it's worked up in your textbook as something to discuss. More commonly is if there's an abrupt withdrawal of glucocorticoids, which actually happens when patients just don't take their meds, or an overtreatment of their Cushing's syndrome. Long-term, chronically, a chronic insufficiency is called Addison's disease, where someone needs to then daily take glucocorticoids to supplement for what their body doesn't have. And I think Addison's disease is common enough that you might see your share. These patients with this adrenal insufficiency long-term present with progressive symptoms, hypotension, fatigue, weakness, vomiting, weight loss. But normally when you see them long-term chronically, you get it worked up, especially with endocrinology. It's Addison's disease and it's treated with glucocorticoids. And again, this is when they have a long-term adrenal insufficiency of these adrenal hormones. In Addison's disease, usually it's due to, again, it could be abrupt, but specifically with the Addison's, that's more chronic. There's some sort of a long-term progressive damage. Common causes can include like an autoimmune destruction. And here in the United States, it's mostly what we see is an autoimmune destruction of the adrenal glands leading to Addison's disease. In other countries, tuberculosis can actually, not treated, can lead down to the kidneys and destroy the adrenal glands, causing Addison's disease, and rarely could be a metastatic carcinoma. The autoimmune disorder causing that inflammation, adrenalitis, can be actually part of any type of autoimmune endocrine disorder where you could see inflammation of the adrenal glands from an autoimmune system causing signs of Addison's disease. You could see that in other forms of autoimmune disorders. But more specifically, we're talking about Addison's disease. So again, it could be primary, which is specific to the adrenal glands. It could be a deficiency of hormones, which is secondary, which we talked about this earlier, which would be part of the pituitary. So something wrong with the pituitary causing a lack of glucocorticoids, causing Addison's disease. Or it could be tertiary, right? So higher up at the hypothalamic level, causing a decrease in glucocorticoid development at the adrenal glands again. But because it's at the level of the hypothalamus, that's the problem, that's considered now tertiary. If a person presents with like a primary adrenal insufficiency with a high ACTH, you're going to present with hyperpigmentation, hyperkalemia because of the low aldosterone. And again, this is specifically related to primary adrenal insufficiency. Again, thinking about primary being at that first level versus if it's secondary or tertiary insufficiency, is really not going to see those changes in the ACTH. So you're not going to see the hyperpigmentation and they're going to have normal aldosterone. So you expect normal potassium levels. So again, thinking about if it's primary, how that affects ACTH and hyperkalemia with aldosterone changes versus if there's secondary, tertiary, and the functioning of ACTH and aldosterone at those levels. Lack of an ACTH response, and there's a stimulation test called the Metropome stimulation test that can help you tell if it's a secondary or tertiary cause. So think, because we've been talking a lot about stimulation tests and ACTH, right? So if you give this mertropione stimulation and there's a lack of the ACTH response, so again, we've been talking about this today. We'll make sure it's coming through. Then you know the problem is more of a secondary issue, right? Because you would expect ACTH to respond. If ACTH is not responding, then you know the problem is higher up. It's either secondary or tertiary. If ACTH does respond, then you know the pituitary and the hypothalamus are working. It's not a secondary tertiary issue. Okay. And if you do a CRH stimulation test, and I do hint, like, you know, for you to understand stimulation tests so that you understand what's expected, I would expect, you know, for you to get some questions on stimulation tests. In a CRH stimulation test, if the ACTH responds, then that suggests a hypothalamic tertiary disease. So think again about that one. CRH stimulation is at the hypothalamic level. If I give CRH and the person responds, ACTH responds, then I know that the hypothalamus didn't have what it needed, didn't have that CRH. giving CRH stimulation then caused this ACTH to respond, I know the problem is at this higher level, it's at this tertiary level, okay? So again, understanding that CRH is here, ACTH is at secondary level, affecting the adrenal glands, which is the primary level. CRH, the example I gave earlier about putting gas in the car, right? If I put gas in the car, if I'm putting CRH in the body and the car moves, right, the ACTH responds, then I know the problem was that I just didn't have any gas, right? I didn't have any CRH. Does that make sense? If I gave you CRH and I still don't get any ACTH, then I know gas isn't the problem. I have, you know, my hypothalamus is working. The problem is lower down. It's probably at the pituitary. So I try to use that gas, like if you put gas in a car and it moves, then I just didn't have any gas. Same idea here. And so the treatment for this is a glucocorticoid or mineralocorticoid, again, depending on what's missing in Addison's disease, depending on where, again, which glucocorticoid or mineralocorticoid is missing. Okay. In regards to the adrenal medulla, again, that's the middle part of the adrenal glands. It's composed of neural crest type of cell, which are these chromaffin cells that could lead into, you could see this adrenal medulla type of cancer. Again, these neural crest-derived trophin cells. And this is where you find epinephrine and norepinephrine. So again, this more leads into a neuro lecture, but this is the source for those catecholamines. And if you have a tumor in this area, in the adrenal medulla, we call that, it leads to pheochromocytoma. And the clinical features is really when there's these episodic release of catecholamines. So leading to an episodic hypertension, tachycardia, palpitation, sweating. I want you though to make a distinction between an adrenal medulla pheochromocytoma and like hyperthyroidism. So hyperthyroidism is considered like chronic, long-term persons constantly like they're losing weight, they're tachycardic, hypertensive, but it's more like chronically versus in pheochromocytoma, this is more like just in one episode, one night, whatever, you took their blood pressure, they're normally like normal blood pressure, and this person is like 210 over like 160, right? They have this pounding headache, tachycardic, like 130s. This is a tumor possibly of the chromaffin cells. You could actually diagnose this by checking for increased epinephrine catecholamines in the serum and the urine, especially if it's very acute like that and they're in the emergency room. Again, some of you do work in the ED. I don't know if you've seen pheochromocytoma being diagnosed. You would have to remove the adrenal glands. That's the treatment for this. The problem with an adrenalectomy is when you remove that, those catecholamines can actually leak into the bloodstream when you try to manipulate the tumor and cause even a worsened form of pheochromocytoma. So what we do is give it's an irreversible alpha blocker followed by a beta blocker before in the emergency room. And that helps with the manipulation of the tumor to prevent these hypertensive crises. And so that's done before doing an adrenalectomy. So again, I don't know if anyone here has seen pheochromocytoma or removal of the adrenal glands, preventing you know, the leaking of the catecholamines. I always think that's interesting. And I just put down here that it follows the rule of 10. So again, pheochromocytoma, not very common necessarily, but it's usually 10% bilateral. So not normally would you see it both sides. Sometimes there is, but rarely a family history. Rarely is it malignant. So again, 10%. And 10% times it is found outside of the actual adrenal medulla. So even though we term it as an adrenal medulla tumor, 90% of the time it is, there is a small chance that it's found in either the organ of Zuckerlin, which I think I talked about that in the GI lecture, at the inferior mesenteric artery root, or you might actually see this tumor at the bladder wall. Same thing though, it can actually still cause problems with catecholamines. So just something to know about the adrenal medulla. I really don't get into much else otherwise. And I just put the slide up so you see the connection between the adrenal medulla and the catecholamines. Tyrosine is here, and it breaks down in your body. So tyrosine can be found in actually some foods and some red wines and so forth. And it actually breaks down your norepinephrine, MAOs, and breaks down into VMAs from the norepinephrine into epinephrine. When you break down norepinephrine, you can actually test for VMAs in the urine and blood. And that's how you know if there's a release in norepinephrine, breaking down to epinephrine. And that's one way to test for this. I don't actually test you on this process. It's more so two things to take away from this. Later on, when you're in advanced patho, they're going to talk about MAOIs, which you probably have already heard of. MAOs breaks down norepinephrines. And that's why when someone's on like psych medications and MAOIs, you want to be careful with norepinephrine and epinephrine and so when someone's digesting tyrosine, because that could actually affect the metabolism of the MAOs. And MAOs are needed for breakdown of norepinephrine. So I leave this up here more so to feed your knowledge so you understand the connection of what we're testing, its relationship to MAOs, its relationship to tyrosine. And then later on, when you do have this again in advanced patho, hopefully you remember the connection of when someone is on, which we don't really use MAOI so much anymore in the United States that I'm aware of. But again, that connection with that and this translation from norepinephrine to epinephrine, I think is important. Oh, what did I say? Yes, advanced pharm. Did I say advanced patho? What did I say? So yeah, in advanced pharm, I'll talk to Dr. Johnson and Mary Brennan, but MAOs is something to be familiar with, and it really does play a role here. So I thought that slide is helpful. I'm going to be going through exam questions, makeup questions for the exam. If I come up with anything good, I will try to share them. I do have some practice questions I will share with you. I think it's a good idea to share the questions now. I don't expect you necessarily to understand it fully because we're still in the middle of lecture. I'm hoping when you go through your notes and then process and take time to digest it, and then maybe go back to this lecture, then you're like, oh, okay, now I understand this practice question, hopefully. If not, reach out. I'm definitely I still have some emails of students I need to get back to go over study tips and things like that. So if I come up with more or better study questions, practice questions, I will share those. Okay, so yeah, I'll work on that. I think that's it. Okay. Any questions? Of course, I will stay here. I will be getting back to you. I know I got some emails, just students to meet up with, to go over some things before our lecture and exam. Other than that, you guys are free to go. And thank you for staying with me.